Hello, this is Fiona Erickson, and you're listening to RN Radio. RN Radio is brought to you by Georgetown University's School of Nursing and Health Studies and Nursing at Georgetown, the school's online master's degree program in nursing.
Today our guest is Julia Lange Kessler, who is here to speak with us about midwifery and potential myths surrounding it. Welcome, Julia.
Thank you.
Could you go ahead and tell us a little bit about yourself?
My name is Julia Lange Kessler. You've already introduced me. I am a midwife. I have been a midwife since 1981 and helping women with birth since 1981. I started as a doula, which is a professional labor coach, and I went on to be an apprentice midwife. I was a lay midwife, and then I got my certificate in midwifery from downstate in Brooklyn, and then went on for a master's in midwifery from the University of Philadelphia, my postmaster certificate from Penn State, my doctorate of nursing practice from Mass General Hospital in Boston, and now I am the program director at Georgetown University for the Nurse-Midwifery WHNP program, which is entirely online.
That is quite a litany of educational experiences. You mentioned that you spent some time as a doula, and for listeners who may or may not be familiar with the term, would you mind expanding a little bit on what that means and what that scope of practice looks like as compared to, say, a midwife or your more standard OBGYN doctor?
A doula is a person who's a professional coach. They shouldn't do anything medical. They're not there to take your blood pressure or make any medical decisions. They are there for emotional support, to maybe make suggestions in terms of maybe it's time to take a rest, maybe we should get up and walk together, maybe we need to rock on the birth ball, those types of things. Those are the kind of things that they would do. They are women that are knowledgeable about birth, and they may be able to help in all kinds of different emotional ways. That's really their primary focus, because when a woman is in labor, she's very, very vulnerable. And while it's nice to have your partner with you, your partner may or may not have ever been at a birth before. And your partner may or may not know how to help you. And even if they go to childbirth classes, they may not know how to help you. So that doula is that woman or person who actually has some experience and will take you calmly through the birthing process and can give you backup education when decisions need to be made. So I think that kind of rounds out what a doula does, and I think doulas are fabulous. I love to work with them. I think that they're great, and it's always nice to have another pair of knowledgeable hands. A midwife does all that a doula does, but she also helps to make the medical decisions, helps to interpret that you're safe and that you are stable and that it's safe for you to continue with your labor as it is. So you might say to me, well, this labor is going on too long, and I can say, well, actually, this is a very average time that you're having your labor, or kind of we can make suggestions in terms of pain relief. We can offer pain medication. And also the difference between a doula and a midwife is that a midwife can care for you, of course, throughout your lifespan and can also do all of that prenatal care and everything else that goes along with pregnancy and birth and afterwards. So if you were to have your baby vaginally and you needed some stitches afterwards, a midwife can do that. If you needed a C-section, a midwife cannot do a C-section, but she can go in and first assist. So she stays with you throughout, and she helps the doctor who's doing the C-section, meanwhile still hopefully keeping you calm and that type of thing. And so midwives do take care of, as I said, throughout our lifespan, and we do all of the same things that doctors do, except for we do not perform GYN surgery, or we do not perform that C-section. So that's a bit of a difference that we have. And we don't shy away from primary care. So that's a little bit of a difference that we have, is that we're not going to do your C-section, but we certainly can make the decision and make the call that you need a C-section. And so that means I'm going to call my doctor in and say, you know what, she needs a C-section. We hopefully are going to listen to you and stay with you a little bit longer in the birth. We may labor sit, meaning that we'll sit there with you while you're in labor. We will offer suggestions. We support normal physiological birth, and that means that you need to have a presence and that doula is one presence, and the midwife can be another presence, and that type of support, that type of female support around you when you're having a baby, studies have shown that it really reduces the risk of C-section, it really reduces the pain medication that's necessary. You just need to know you're not alone, and that what you're feeling is normal, and that's what we want to do, is support that normal physiologic birth.
What brought you to midwifery and made you want to pursue it?
Well, I saw through my own experiences that midwifery really makes a difference in a woman's life. So my first birth was in a hospital and with OBGYN, and my second birth was with a midwife at home. Not that very many midwives deliver at home. Hardly any of them do. Only about 15% of midwives do home deliveries. But my second birth was at home, and when I got done with that birth, I was so empowered by it. I felt like if I could do that, I could do anything. And I thought that that was a very important aspect that other women should feel, and I wanted to be able to help other women get to that place where when they gave birth, they not only started out and got through it in a healthy place, but they also emotionally got through it and felt like they were a lioness, that they could become fabulous mothers and take great care of their children because they were powerful and strong.
That's beautiful. Thank you for sharing that personal story. I guess to elaborate on something that you mentioned, the empowering nature of midwifery and the way that it empowers women and helps them to start their family strong.
Mm-hmm.
Stepping aside from your experiences, what do women in general stand to gain from access to midwives?
Well, access to midwifery, they can gain quite a bit, actually. So midwives have a much higher satisfaction rate among females, and they also have a much lower cesarean rate. They have less medication, although if you want medication, a midwife will give it to you. We don't hold back on that. And they have just healthier outcomes all around. So in the rest of the world, where in many other patient populations and other countries where midwives are the primary care providers, they have much better statistics than we do. And we are way down on the list for maternal mortality and infant mortality. So you just have a better outcome, in my opinion, and not just a better healthy outcome, but a better emotional outcome, because midwives partner with you in your health care. We don't say you have to do it our way. We work together to do not only informed decision making, but shared decision making for your health outcomes.
Do you think that part of the satisfaction increases have anything to do with the sort of extended method of care, where midwives are caring for the whole woman over her lifetime, not necessarily just in pregnancy scenarios?
Yes, I do, because midwives can take care of women throughout their lifespan, and I'm glad that you pointed that out, Fiona. So as midwives, we can do all aspects of women's health care, starting from the time you get your first period right through menopause and beyond. So we do primary care, which means that we can take care of your common ailments that you have or help you with other chronic disease states, some of them. And then we do GYN, all kinds of GYN care, and pregnancy care, birth, postpartum care, newborn care up to 28 days. And then we can provide gynecological care for a woman throughout her life.
You've obviously had a long and rather illustrious career in midwifery. What misconceptions have you encountered, given that it's not a particularly well understood field of work?
Yes, not well understood here in the United States. I'll have questions like this. Oh, you're a midwife? That's legal? So that's one misperception, that yes, we're licensed in the United States and we have quite an education, at the very least a master's degree, and a good percentage of midwives also have doctoral degrees. So beyond that, the other misconception that I would say to you is that, oh, midwives, they only do home births. And the reality is that no, 85% of midwives practice in hospitals, in private practices, in all kinds of different settings. And only 15% are in out-of-hospital settings. So that includes birth centers and home births. And we do believe that home births for the low-risk women are safe, and out-of-hospital births for the low-risk women are safe alternatives. And our professional organization, the American College of Nurse Midwives, also supports that particular issue, that we are safe no matter where we are. And it is within our scope of practice to make that call. So say you're at home And that's the other thing. It's not do or die home birth. It's only home birth if it's safe to be there. So say something comes up like your blood pressure starts to go up, or the baby's heart rate doesn't sound exactly right to us, or you start to develop a temperature, then you shouldn't be at home. We are going to take you to the hospital. We're going to make sure you get to a hospital and hopefully to another midwife in the hospital so that we can care for you. Or if we're really lucky, we have privileges in that hospital ourselves and we continue to care for you. So it's not do or die home birth. And so that's one of the things that I like to say. And the other thing, the other myth that I would tell you is that many people think, oh, if you go to a midwife, that you can't have medication while you're in labor. And while we will offer you alternatives, we will walk the hallways with you. I will rub your back. I will talk with you. I'll even sing every once in a while. If you say to me, I want my epidural in the parking lot before I even get in the door, then I will give you that epidural. So we support normal physiological birth. So we do offer alternatives and we will help you with those if you want them. But if you don't, it's your choice. As long as you're making an informed decision about it and you understand the benefits and the risks, then I'm fine with that.
To go back to the first point that you raised on midwifery and the misunderstanding about the qualifications that go along with practicing midwifery, in particular the education, could you offer us some insights on what the tenets of that education are beyond the physiology and the biology, but what the core beliefs that you try to impart upon your students are?
Well, let me just tell you a little bit about what midwives go through to become licensed, and then I can tell you the focus of our program.
Perfect. That would be great.
So, of course, midwives have to come to the profession with a strong science background. And in the United States, we have both CNMs, certified nurse midwives, and certified midwives. And when someone is a CNM, it means that they came from a nursing background first. But in the United States, we also recognize that certified midwives can have very strong sciences, and then you can go into midwifery. It's just like we wouldn't ask a cardiologist to become a nurse first and then be a nurse cardiologist, or a doctor to become a nurse doctor. We would ask them to have strong science background. So midwives have very strong science backgrounds, as you referred to, all the ologies, I like to call them, as well as nutrition and pharmacology and a number of different sciences. And then they come to the master's program with a bachelor's degree in those sciences and nursing. And in our program here at Georgetown, they have to have a nursing degree. And then we do some advanced sciences, and then we go to our core clinical courses. So in the core clinical courses, they'll be taking a course in gynecology, and then they will also be doing a clinical course that correlates with that. Or the next course will be pregnancy care or advanced GYN care, and there'll also be a clinical course that will correlate with that. And at the very end of the program, we put them into a course called integration, where we integrate all of the other clinical courses together, and they get to be the midwife for that entire semester. And they are working and living the life of a midwife. So it's 40 to 50 clinical hours per week, and they are the midwife, and their preceptor works with them to make sure that everything is safe and that they stay safe. Preceptors are midwives in a hospital or out of hospital setting that work very, very closely supervising the student throughout their clinical rotations. So at Georgetown, we really want our students to be, of course, excellent. We are very, very careful about where they are placed clinically. We want to imbibe all of the values of Georgetown with social justice and caring for the whole person and treating others the way that you would want to be treated. And in thinking about really specifically in terms of midwifery, we do want to take into consideration the entire person. So it's not just about that we can provide care for you. It's also what's going on with your family, what's happening in your life that this kind of stress is causing this condition. What can we do to get the services for you to alleviate some of that stress, or what can we do to help and to bring you to a place of self-care and taking not only good care of yourself, because once a mom takes really good care of herself, the research shows that she is the lifeline for the rest of that family, and she is the entryway into healthcare. And she's the one that makes the healthcare decisions. And so we want to make sure that she's empowered with the best information and the best education. So we have a saying in midwifery that we listen to women, quote unquote. And we do listen to them, but not only do we listen carefully, we also spend a lot of time in patient education and making sure that she has the information that she needs in a health literate type of way so that she understands.
That's a lot to cover in one master's program. I'm impressed. I have heard a little bit about the myths that you've mentioned, from the education to the pain medication to the home birth, being sort of misconceptions that the public might have while making a decision about where to seek prenatal care. Who is the onus on to clear up those misconceptions, and how do we go about doing that?
Well, that's a big question. As midwives, we work with our consumer groups to try to clear up those misconceptions. And as someone who's really involved with the professional organization, again, the American College of Nurse Midwives, we also work on clearing up those misconceptions. But the misconceptions have a life of their own, so to speak. And so it is a little bit hard to overcome in this country because we are not the largest profession. So the midwifery profession, there are 11,000 of us. And so we're a small profession comparatively. And then there is this perception here in the United States that if you go to a midwife, you're going to someone who's lesser than, rather than you're going to someone who will give you a full complement of care. And I want to just preface that by saying, but we also collaborate. So if I need a doctor, if a situation becomes high risk, then we're going to consult with our medical collaborators to make sure that we are getting the best care for our patients and taking the best care of them. So no one really practices in a vacuum. No one practices in a silo. We have to have interdisciplinary conversations because that's the way that we keep people safe. And I would hope that as not only the public learns about midwifery, but also other health professions learn about midwifery, that some of these myths can be dispelled.
It's so interesting to hear. What is your hope for the future of midwifery? You've spoken a little bit about the interdisciplinary understanding and the ability to work together with other medical care professionals. And so if you were to look 10 years into the future, what would being a midwife look like in the field of medicine?
Well, 10 years into the future, I would hope that given the focus right now on interdisciplinary education, that there's a lot more understanding about what midwifery is and what midwifery can do for women. And so that I would hope would be not only an easier way for midwives to practice, because the easier it is for us to practice, the more women we can help. So I would hope that the interprofessional and the interdisciplinary way that we work together could become easier, and I hope that the internet will help with that, and that hospital systems and perhaps the Affordable Care Act will help that all to kind of gel together 10 years from now. But if you're going to ask me 25 years from now or 30 years from now, maybe even sooner, let's put it out there that it could be sooner, that we could have a midwife for every woman that wants one, and that we could grow the profession so that when you want holistic care from another woman, that you can get that, you can look and you can see a midwife in every town, a midwife. I mean, we have some states that only have a few midwives in them, like 3 or 4 midwives. I mean, we need a lot more midwives across the United States, and I think we can really improve the quality of health care if we were to have midwives for every woman.
You obviously were fairly initially drawn to midwifery. If you were speaking to, let's say, a listener who's contemplating where they'd like to go with their nursing degree, and midwifery, nurse midwifery is on the table, what would you say to those prospective listeners who might be on the fence about it? What really was the deciding factor for you that brought you here? What would you impart upon them?
I would say to them that if you're considering midwifery, find out something about the profession and about what it really entails. The reality is that when it comes down to it, you are making life and death decisions for 2 people. So it's not just the mom, it's the mom and the baby. So it's that dyad that you have to care for. And we can't just think about one part of that, but during labor and delivery, that part of your midwifery practice, that's the part where you put the pedal to the metal, so to speak, and you have to be ready for all kinds of different things that could come up. If you're somebody that panics a lot, then I would say this is not the profession for you. But I would also like to say and like to just impart that midwifery is a really beautiful way to spend your life. That it is, for me, being at a birth is like being in church. It's holy and it's miraculous and it's pretty incredible. And so it's a really, really nice profession. It's a lot of fun. But it's not always fun. So you have to be prepared for the unfun days too. And you have to be ready to take them on. So in thinking about someone that's considering midwifery, and maybe I can say to you where I see people go wrong is that they get involved with the romantic notion of it, because it is rather romantic, but not realizing that really sometimes it's a lot of hard work. So when I said to you, no, I'll rub your back, I'll do this, yes, and by the time I get done with your birth, I'm going to be sore too. So, we'll both be sore together and that kind of thing. But just helping women to, when you see somebody holding that baby in their arms, it's just magical. It's just really, really magical. And when you can help them with breastfeeding and help them just to realize what it means to be a woman and how incredible women are, it doesn't get better than that.
Before we bring the audience to tears with the romantic aspect of midwifery,
let's get back to the facts.
To sidestep a little bit about a point that you mentioned earlier, the global aspects of midwifery, how some countries have more midwives than we do and they're more prevalent and better understood and utilized, and then some countries have problems meeting skilled care needs at all in any fashion. Where do you see midwives in the progression of medicine worldwide fitting in?
So let's just talk a little bit about those countries that have a lot of midwives, like in New Zealand and in the Netherlands and those European countries. Many of the European countries, midwives are the first layer of care. So before you can even get to a doctor, you go to a midwife first, and the midwife decides whether you are low risk or high risk. And if you're high risk, then okay, she may send you to a doctor or she may co-manage your care.
Could you briefly elaborate just what low risk and high risk looks like?
So low risk would be someone who's essentially healthy and without disease state. Like I wouldn't want to particularly take care of someone without collaborating with a doctor or co-managing with a doctor, someone who has epilepsy or someone who has insulin-dependent diabetes or somebody with some other type of disease state that would be out of the range of my scope of practice. So we stay within our scope of practice. If you become hypertensive, I'm going to call your doctor or call my backup doctor or my collaborating doctor, and I'm going to say to him, this is what's happening. I think I should prescribe this, and do you agree with me? But if someone is too high risk from the beginning, we're going to pull the doctor in right away.
Perfect.
Thank you. That would be high risk. Someone with a genetic disorder, those kind of things, I would want a perinatologist or an MD to be involved in.
Of course.
So low risk is basically your healthy woman. And in those countries that I was talking about, you go to the midwife first, and then she decides whether you're low risk or you're high risk. And she is the first point of care. And those countries, if you take a look statistically, you'll see that they have much better outcomes for maternal mortality and infant mortality than we do. And we do see that the correlation between the number of midwives really impacts a country and their health outcomes. So in the countries where access to care is problematic, the recent Lancet series and a number of other reports that have come out really point to the World Health Organization, the list goes on and on, really point to midwifery as the solution in those countries where there are very, very high infant mortality and maternal mortality rates. So I've done some work in Haiti, I've done work in Rwanda, I've done work educationally in those countries, trying to help educate midwives and to create more midwifery education in those places so that they have the skilled professionals that they need. And I do think that it's not only my opinion, it is the opinion of many, many scholars that midwifery is the solution. And so that's why we have to make as many as we can. And that's what we do at Georgetown with a program. Women can practice in their own community. We call it community-based education. So we bring our educational program to you. And you still get to go to class every week. So you're in class, like last night I taught from 6 to 9. And I brought the classroom to each person's home. and they sat in front of their computer. They could see me, I could see them. We could do our lecture, we could share PowerPoints, we could have discussion, and we could do all of the things that we needed to do just as if we were in a classroom together. And then tomorrow when they go out, they'll go out into their community, into their clinical placement, which we find for them, and they will have an educational experience in the clinic setting. And when they get done with their midwifery education, they will stay in their community and bring that great resource to their community.
So we're really seeing pushes from, say, you mentioned the World Health Organization, to take that community-based learning model that Georgetown uses and sort of expand it.
We're hoping to take it international, yes.
Bring the education to the people.
Yes, exactly right.
It's fantastic. So to just wrap up what we've heard so far, there are definitely, and correct me if I misstep at any point here, definitely a couple of misconceptions in America specifically about the practice of midwifery. You personally, anecdotally, mentioned the prescription of pain medication or the use of pain medication, the practice of home births, and midwives' educations. But as we've learned, midwifery is really about the midwife-patient mutual decision-making and education. We really appreciate the time that you've given us. Thank you so much for coming in, Julia, and speaking to us about midwives and clearing up all those misconceptions. Thank you.
It's been my pleasure.
I'm Fiona Erickson for RN Radio, the podcast for nurses and nursing students with a passion for learning and staying informed. For more information on Georgetown's online master's nursing programs, please visit online.nursing.georgetown.edu. Join us next time for more on RN Radio.